Hi everyone, I'm at the NNN this morning. I think a lot of you know that I've come to do a Facebook Live with the infant feeding team. So we've got Louisa and we've got Lucy. Louisa does 3 days as the infant feeding coordinator, and Lucy also works as part of the team. We're actually in one of the MLBU rooms. I'm just going to quickly show you. This is one of the rooms that if you might have had a baby in the past in MLBU, or you might be watching this thinking you want to see what it looks like. Got a lovely photo of lavender, what could be more relaxing, and you've got your bed, and it just brings back so many memories. I was never on MLBU, but just being in the hospital just reminds me of my time, and being in the lift even. I remember leaking waters in the lift and someone getting in the lift before me, and even though I was contracting heavily and obviously in pain, they got off at the floor below me. So I was in the lift kind of waiting to get to the ward, and this person was like pressing the next button to get off before me. But it brings back all these memories, and it's really lovely to be here, and I'm so pleased because apparently no one's ever done this before. No one's ever done a Facebook Live at the hospital, so this is really lovely. So we're going to ask some questions. So people have sent me questions to ask the infant feeding team. There's been quite a lot of questions, quite a lot of issues, so I'm just going to go for it. Right, we'll start with a nice, not a nice one, because obviously it's breastfeeding can be very hard, but the first question is, what is the normal amount of pain or discomfort, and what is a concern, what kind of pain would be a concern that you should get support for? So I think someone wants to know what to look out for when they're breastfeeding. So obviously some people say it shouldn't hurt you, whereas some people, I know my experience was it was really quite painful. So from a professional point of view, what would you recommend as an amount of pain to get checked out for, or do you just stick with it?
So it shouldn't be painful. That's the bottom line. It will be uncomfortable for usually the first 10 seconds at the start of breastfeeding. But in most cases, women who've got pain past 10 seconds, there's something not right. Whether that's a very subtle tongue tie that's causing a problem that wouldn't have been picked up a few years ago, or sometimes doesn't get picked up today if you don't see the right person at the right time, or whether it's positioning and attachment that just needs to be tweaked a little bit. So basically, if you've got pain, your nipple's being usually squashed, compressed on the hard palate of the baby's mouth, or the baby's using excessive suction, in the case usually of a tongue tie, and that collapses sometimes the little ducts in the breast, or just, if you imagine a high level of suction that we see in
is it more painful if your nipples are more sensitive, like because you're just not used to having a baby attached to them? Like,
and sometimes people feel it's deciphering whether someone's describing pain to you or a weird feeling. It is slightly strange if you've never had that experience before. It's like a pulling feeling that, but it's deciphering when you're supporting someone. Is this pain or is this not? And if it's pain, we need to unlatch the baby and try again and try and get a fuller latch. And there's techniques that we can use to try and help that. And always making sure that you seek support as soon as possible if you're at home in the community, so that somebody can check your latch.
I think it's worth saying as well, very occasionally we struggle to find the cause of pain. So some women, despite breastfeeding maybe 2 or 3 times before with no problem, suddenly on their 3rd, 4th, 5th baby have pain. And that's a real red flag for something going on in the baby's mouth, in normal anatomy, whether that's a high palate as well as a tongue tie or instead of, or there's another issue with oral anatomy. And I've had friends who've been experienced midwives who've suddenly developed painful feeding, and I know how distressing it is when they're searching for answers, thinking, but I know exactly how to position and attach my baby. I've been teaching this for years, or I've had other babies and I've fed them for years. I feel like I'm doing something wrong, and I think then it's really, really horrible for women because they think, I can't get this right, I'm not doing this right, and it's my fault, and obviously it's not their fault at all. So it's about seeking support, knowing that it's not normal, and getting an early referral to us. But I have had very rare cases, and I say friends, who we've done everything we can, and it's taken them several weeks to get pain-free feeding, even when they've had tongue tie divisions, even when they've had loads of help and support. So very occasionally, it is just for a very, very small number of women, the fact that they do get pain. So we're saying, well, you shouldn't have any pain. It's fine for the majority. But I don't want women to interpret that as I'm doing something wrong, because they're not. But if you've got pain, as Lucy says, we need to unlatch the baby, we need to look at what's going on, and we need to work through various things to improve the latch. And if we've improved the latch so it's perfect, and you've still got pain, then we need to really assess tongue function. And as I say, sometimes it's really subtle. So over the years I've known ladies where there's a very minor restriction to, say, the left side. So the right side of movement's normal, the lifting up and down is normal, the sticking out is normal. So technically there's not really a tongue tie. But when I've run out of ideas, I've referred them to Mr. Minocha before I became a divider myself. And thinking, there's not really there's the tiniest degree of restriction if you really look for it. And he's divided it after discussion with the parents, saying, I don't think it'll make a difference. And those parents have then got in touch to say, oh my God, huge difference instantly. So we don't fully understand everything yet. We don't know everything yet. And the more I see, the less I feel like I know. But the bottom line is, if you're having problems, get in touch. We have a specialist service. We've got our team, we've got lactation consultant clinics, so don't suffer.
Okay. I'm just going to quickly check that it says people are watching. Could anyone give me a hi if you can hear us, just to make sure? I don't want there to be no sound on this whole video. So if someone who's watching can just say hello. I can see a few people are watching. Anyone can give me a quick hi, or a wave, just something to say you can. Oh, so Jade, hi Jade. I'm guessing you can hear us if you've commented. Oh, hi Davina. Yes, great. Glad the sound is working before we continue. I just had a horrible vision that we do like a half-an-hour video, there'll be no sound.
No one can hear it.
Okay, so number 2. So you talked a bit about tongue ties. Someone said, why don't they check for tongue ties on delivery suite prior to discharge? It seems a fairly common ailment, and it can floor someone's breastfeeding efforts, especially when referrals for the procedure to rectify it could take so long. And it's such a speedy procedure, so scissor snip with no anaesthetic. You could do it on the delivery suite to those affected. Now I know tongue tie is one of the big things. Quite a lot of people contacted to say about tongue tie. Do you want to tell us a little bit about what you do for tongue tie?
Yes, so my other role is a tongue tie specialist midwife, which I do 2 days a week. So I see about 20 women a week in my clinic. And I've done it for the last year, love it, absolutely love the role. It's true that our waiting lists are long, unfortunately, and that's mainly due to the fact that we cover a large area of the east of England, because unfortunately at the moment there's no service in Suffolk at all, no service in Ipswich, very, very minimal service at James Paget and at the Queen Elizabeth. Well, there's a service at the Queen Elizabeth, but in Lincolnshire there's no service, Peterborough there's a minimal service, Cambridgeshire. So we cover all of that area. And half of our referrals, of our 160-ish a month, are out of area. So if we just had our own NNUH, catchment women, we would be able to cope with the demand. So our focus is partly on encouraging other services to be developed and training them and supporting them. So that's going on in the background. In terms of why we don't check at birth, and I'm asked this all the time, and I understand why, we produced a parent information leaflet 2015. So I've got that on our website, and I'll give you a copy of that to upload. But essentially what that says and what it explains is why we don't check at birth. It sounds like the perfect solution, and I wish we could check at birth. But the thing is, not every baby has got a tongue restriction that's visible. So sometimes you'll have a visible lingual frenulum, the frenulum under the tongue. And some people have got a really obvious anterior, we call frenulum, so where you can see it easily. And they've got no problems at all with feeding. So you can have a baby with a very obvious anterior frenulum where on a picture you would say, oh, that baby's got a tongue tie. No problem with feeding. It's nice and elastic, it's got a good range of movement, the tongue mobility is normal, and there are no symptoms. Mum's feeding like a dream. So would we treat them? No, of course. There's no symptoms, there's no tie. So that's why we don't use the term tongue tie if we can here. I know a lot of other places do. But Mr. Minocha and I try to use, and our team use the term restrictive lingual frenulum because it describes what the problem is, which is the function of the tongue. So you can have a tongue that's very restricted with no obvious frenulum at all. So in terms of checking for a tongue tie, there's nothing to see. So that's why it's not the perfect solution. What we do is the method of checking whether there's a problem with feeding is our breastfeeding assessment tool. And we do that 4 times in the first 10 days. So we do it before you leave hospital or before midwife leaves the home if you've chosen a home birth. We do it at the first midwifery visit, which is usually day 1 or day 2 at home. We do it again on day 5 when we do the neonatal screening test, and we do it again on transfer to health visitor, so maybe around day 10 or day 12. So 4 times in the first 10 to 12 days, that is ample opportunity to pick up any feeding problems. Now obviously it might not be a tongue tie that's causing the problem, it might be position attachment, but it enables us to say, okay, what's going on? So that if I read you the symptoms of symptoms that are caused by a restrictive frenulum. There could be suboptimal latch, shallow latch, baby drawing their cheeks in, feeding for less than 5 minutes or persistently more than 40 minutes, incomplete breast drainage resulting in engorgement, blocked ducts, nipple blebs, nipple soreness, nipple pain,
Nipple blebs.
blebs, so a little white spot on the end of the nipple.
Oh,
It's like
okay.
a whitehead.
Right. Yes. Yes.
Excruciatingly painful. It's a blocked nipple pore. Right. That can cause.
I didn't know it was called a bleb.
problems. A bleb. Yeah. So yeah, sore damage, cracked nipples, ulcerated nipples that are lipstick shaped after a feed. Fewer than 6 feeds in 24 hours, or more than 14 feeds in 24 hours persistently. That would be a red flag as well. Coming on and off and on and off and on and off the breast. Taking ages to latch. So maybe, you know, getting the fists involved, getting frantic at feed times, very angry, frustrated, unsettled, head banging at the breast like a rocker. These are all signs of a restrictive frenulum, but they're also all signs of ineffective attachment and positioning. So we have to rule out the fact that there's no problems with positioning and attachment as a differential diagnosis to say, okay, so positioning and attachment is fine, we've done exaggerated attachment, which Lucy's going to talk through, and we've still got problems. Now you might tick one of these boxes or all of them, it doesn't matter to us. If you have a problem and it's definitely not due to positioning and attachment, you definitely need somebody qualified to look at the baby's tone ability. So the second part of the problem, in answer to the question, is we'd need to train 300 members of staff potentially to be able to assess tongue function, because it's not something that you can train quickly. You can train it. My teaching sessions are 3.5 hours that I deliver outside the trust to other trusts, and we do a full study day with Mr. Minotia, a full 8-hour day where we really give gold standard training. But I can do it in about 3.5 hours as a minimum. To release 300 staff for 3.5 hours is extremely expensive, as you can imagine. So we would love to do it, and we still have the conversation about making it mandatory training.
Oh,
we're back.
sorry. That's okay. The Wi-Fi's doing well so far. I'm quite impressed.
Yeah.
Okay.
So
I
it's
don't
not as
think I'm
easy as
honest.
it sounds. In
No.
summary, it's not hard to check when you know what you're checking for, but we have a system whereby breastfeeding assessment or bottle feeding assessment is done 4 times in the first 10 days. If there's a problem, check position attachment or check technique. If bottle feeding, use different teats. We work through these. If there's still problems, check tongue mobility at that point. And sometimes that happens really quickly on the ward. You know, yesterday I divided 7 babies in an extra tongue tie clinic that we put on, and they were only 2 to 3 days old, some of those babies. So we don't. Sometimes this happens much quicker than day to day. We don't make women away if there's problems. But the oral anatomy changes so much in the first few days of life, and also the risk of bleeding. Although it's a minor procedure and it's a very quick procedure, there is a risk. It's a surgical procedure, putting scissors in a baby's mouth and cutting tissue, which
does sound horrible.
it sounds horrible. It does sound horrible, and in terms of pain, it's certainly less than immunisations. All of our mum tells us it's probably around the same as a heel prick. So it's not nice, but it's not awful. We wouldn't use an anaesthetic for a heel prick. It's certainly, to us, it seems less than cannulation that we do on babies without anaesthetic. So yeah, so it's a minor procedure, but it does carry risk of bleeding. And if your baby is the 1 in 1,000 that bleeds significantly, then to have done that when we didn't actually know if it needed doing would be completely unethical. So we have to put the baby's best interests at heart, and that's why we only do it if there's definitely a tongue restriction, if there are feeding problems, and if the babies have vitamin K, for example, or have clotting studies if the parents decline that, and usually over day 3. Rare circumstances will do it on day 2, but that risk of bleeding is higher under day 3. So that's why we don't do it at birth.
Right.
Yeah.
Okay. Someone wants some advice for feeding with inverted or flat nipples, and there's another question about nipple shields. I don't know if you want to do them. Do you want to do all together, or do you want to tackle them separately? Inverted and flat nipples.
Okay, so this is quite a common problem that we come across. It's not actually particularly a problem for a lot of people. Some people do find it trickier. I've got some breasts here, although
The
they're
good
not,
old knitted
we should have
boots.
got some that were a bit flatter.
Oh.
So some techniques that women can find helpful is to shape the breast so that it kind of gives a bit more protrusion of the nipple area. So you can do breast shaping, so where you get like kind of a C shape, making sure that none of your hands are on the darker area, so can you see? So you're kind of doing a C shape in line with how the baby's coming on. So if I was to be feeding my baby like this, I would shape it in line with their lips, so you're kind of almost making a sandwich or a burger shape for baby. So that can kind of help to make a bit more of something for the baby to get latch onto. So that's one technique that you can do. Another technique would be to do the exaggerated latch, where you're kind of almost putting the nipple away from the baby, so that when they do go on, they're getting more breast tissue in. So you kind of put your
okay, so yeah, so you're flicking it away. So
yeah,
they
some
have
people call it a flipple as well. So
a flipple,
flip the nipple. Yeah. So you kind of press down a little bit further away from the base of the nipple, more like around here, so that can you see how the nipple kind of points far away from the baby's mouth, and then as the baby goes on, and it does take a little bit of practice for some people because it's a bit of a skill.
Well, breastfeeding is generally,
Yeah.
isn't it? I mean,
Absolutely.
Yeah, it's another skill to learn. Kind of as the baby does the lovely big open mouth and goes on, that's when you can let go into, so that it takes the breast further deeper into the mouth, into the sort of soft, the palate.
That's essentially what you're aiming for with all latches,
Anyway,
really, isn't
yeah,
it? Just that
yeah.
really deep.
Yeah, and I think the more you can exaggerate that, a flatter or inverted nipple, the better. Sometimes people find it helpful to go on a breast pump before they feed the baby, because it can pull out the nipple
Oh,
a bit
okay,
more,
yes.
or doing a bit of massage of the breast and nipple area, so kind of tweaking around that
Yes,
sort
I
of
remember
area.
that like lovely odd shape that your nipple comes out of the
And the breast pump,
pump.
yeah, really pulled,
Yeah,
really pulled. So for people who've got inversions or flatness, that can really help sometimes, because it gives baby something that it kind of stimulates their sucker reflex if they can feel that on their mouth when they latch on. In some cases, women might try nipple shields as well for that situation if they're not getting anywhere with these things. We're trying these different techniques. If baby's getting very fractious at the breast, then we can try laid back breastfeeding, so we kind of have the baby in a much more sort of natural position, letting baby root around for the breast, because that helps them to feel more relaxed and calm, and they're more inclined to kind of be more chilled out and therefore take the breast in a more relaxed and successful way. Yeah.
So how do you take care? What's the best way to take care of and use nipple shields? So is there a way?
Okay, so nipple shields are kind of one of those things which people feel quite conflicted about. Some people are really anti them, some people are really pro them, and we get a lot of different variety in breastfeeding support of people who believe them or not. Some mums find them absolutely, they save their breastfeeding journey. And some people use them just for an interim period, perhaps whilst their baby's really struggling to latch because of a restriction. So if a mum is going to use a nipple shield, we do try and talk to them about the pros and cons of that whilst they're in our care, because they need to know that although it may well help, there are some downsides potentially. It can mean that the milk transfer to the baby isn't as optimal as without, because there's something kind of in the way essentially. So that would be one of the downsides, and which then, if the baby's not draining the breast effectively, it can cause blocked milk ducts, potentially leading to mastitis. So there are those sort of risks that we need to let people know about. In terms of using them successfully, I don't think we've got
Do you have to do? Is it like a breast pump that you just sterilise after each use?
Yeah, I think
Is it?
generally you only need to sterilise it probably once a day actually,
Okay.
but obviously you still need to wash it carefully between uses. So you might feed it from one side, and then as soon as that feed's finished, it's absolutely fine just to pop it onto the other side and then use it. But then if it's going to be a few hours before you feed again, you can just wash it in hot soapy water and put it in like a little pot or something. But yeah, we'd recommend sterilising it once a day at least.
Okay.
And there are different sizes of nipple shields.
Okay.
Yeah.
So some people just think it's one side, and obviously people's width of their nipple is different and the length. So yeah, there's small, medium, large, extra. So there's different sizes. It's worth going for the one that looks like your nipple.
All right. I was going to say, how do you know?
There is a guide. There is a guide. So
Right, okay.
in an ideal world, I would always ask if it's okay with them if I measure the width of their nipple, or they can do that themselves. I'll just get them like a little measuring tape, and that kind of informs what we think would be most likely a good one to use for them. and then we'd show them how to use them. And what you kind of need to do is put your finger over the holes to kind of get a bit of suction and turn the nipple shield inside out. The instructions are all on the packaging anyway, but that kind of helps to get suction rather than just to plonk it on. It often doesn't stay on in that instance.
It's turning it halfway out.
Halfway out.
Maybe we could do a little demo and send that to you.
Yeah, okay, yeah.
We have got a parent information leaflet that's just about to be ratified. We're just waiting for the final, and that talks you through exactly.
And what's really important if somebody is choosing to use a shield is that they still get somebody to check their latch, because sometimes what we see is they've got the baby on and they're absolutely overjoyed, as you would be, that their baby's on the breast. But sometimes it's actually quite it looks like it's indented in the silicone or whatever it's made of. We still need to make sure we're seeing a lovely full attachment at the breast.
Is it easier for babies to slip off a nipple shield than it is a nipple?
Potentially, it's almost like they're sucking on the end of it, like it's a teat of a bottle or a dummy, and they're not actually therefore they're adding to the disadvantage of it not draining the breast potentially effectively. So it's really good to get somebody to check they've got a lovely full.
But if they do go on well, we often use them because they help babies to attach who can't stay attached. So we use them a lot for preterm babies who haven't got the little fat pads inside their cheeks, what we call buccal fat pads, that don't develop until about 36 weeks. So if babies are born preterm, they really struggle to maintain that negative pressure, to hold the breast in the mouth. And so the nipple shield is a firmer, rigid structure that's longer usually, so it goes further back in the mouth. And so that's why it can help, particularly in cases of restricted frenulum, or otherwise known as tongue tie. I find myself often recommending them because I see women who've tried everything else. They don't come to me when breastfeeding is going well.
My past experience is that nipple shields are just a no-no because they're going to get what is it called?
Teat confusion.
Yes. So I always thought that people are going to frown upon those. That's really interesting to hear. Actually, they can be a benefit.
They can be, as you say, safe breastfeeding relationships if they're used appropriately. So always get some help from one of us in the team, or from your midwife, your MCA. All of our staff are trained in nipple shields, and I think when we've got our parent information leaflet out at the end of this month, hopefully that'll really help.
Okay. I saw someone had asked a question just up here about how soon you should see the breastfeeding team if there's a problem, and if there's a waiting list. Do you want to quickly do that one before I lose it in the scroll?
So Joe and I share 5 days a week, cover Monday to Friday. And Gail McCartney is the lovely midwife taking over from me as of hopefully from November onwards. I'm leaving on Friday, but what we have is Lucy and Sharon, who are fabulous maternity care assistants in our team, who work on bank basis, so usually covering about 4 shifts a week at the moment. So sometimes we get up to 6 shifts a week. We've got funding for 7-day week cover now, which is fab. So we're really lucky. Our manager Barbara Jackson, the matron of the services, has funded 7-day week cover. So we're just
that must really ease.
It's going to be great when we get 7 days.
It's great on the weekends because I can be here, or Sharon can be here on one of the weekend days, and it just helps when perhaps the rest of the team aren't in and people are still looking for maybe a tongue tie referral, for example, or just need a bit of extra support.
The hours are around 5.5, 6 hours a day though, so it's not 12 hours a day cover, and poor Lucy and Sharon are swamped and they work so hard. So the trouble is, it's not just Blakely Ward, so we get calls from community, from other areas of the hospital. If a mother's admitted, we were asked to see a mum yesterday whose baby's 6 weeks old. That's very common. We spent time on Monday, both of us, going down to our paediatric ward, seeing babies who've been readmitted, babies who are 4 or 5 months old.
I was readmitted at 4 days, I think, because Ada had lost too much weight. So we were given the infant feeding coordinator's details and referred because of that, and then we were on Jenny Lind then. So
sometimes it's for other complications and other ongoing health issues, but they're also trying to breastfeed. So there's we get the complicated issues sort of scattered around the hospital a bit, so we're not always based here, so that does affect our
great
capacity.
News, 7 days.
We are, and we are recruiting 2 new bank maternity care assistants to the team who are amazing, and they're both key workers. So we have a method of training where all of our midwives, all of our maternity care assistants, and all of our nurses and nursery nurses on the neonatal unit are all trained. That's baby-friendly standards, and they're all trained with a 2-day baby-friendly course. They have to be within 6 months. And pretty much all of our staff are trained. The only people now that are not trained are new starters. and they get training within 6 months, but usually within 3 months of employment. So all of our staff have a basic level of training, and in addition to that, they all come and do practical skills reviews with our doll and our boob, and we ask them, you know, one-to-one, show me how you position and attach a baby, how do you teach a mum to hand express, what would you do with this? And so all of our staff are well trained. We're a baby-friendly hospital, that becomes part and parcel of being accredited, and that's taken, you know, 7 years to achieve. But in addition to that, we have key workers who've done an additional day, or sometimes 2 or 3 days training with us, where we touch on more complex management topics, so how to really effectively manage more complex breastfeeding challenges. So they're sort of mini lactation consultants, and some of them have then gone on to sit their lactation consultant exam, a few of them. So, and they are maternity care assistants, nurses, nursery nurses, and midwives in that group. And we've got 105 key workers that cover all teams, all 8 midwifery teams in the community, all areas. Paediatrics, we've got an HCA in A&E as well, lovely Josie. So, you know, we've got people covering as well as we can, but it's still not enough. It's still not enough, and we're aware of that. And I really, you know, want to apologise if anyone's struggled with feeding and not been able to access us. And I know that happens every day. And we both go home feeling sad and a bit useless every day that we haven't been able to see
I think it's
everybody.
worth mentioning though that I've had so many messages. And there's someone here that talk about how amazing the team is and how much you've helped people. So don't be too sad.
We
Don't
understand
be
what we
too
don't
sad.
do.
No.
Going back to your the lady's comment though about how they can access us quickly.
Oh, yes.
So
Answer the question.
I guess it depends where you are, but if you can if you're in a community, speak to a community midwife. You might get a key worker come to your house, so it might be an MCA or a midwife. They can come and do a visit to you, or you can access us by having if they've tried and they've tried to help you and still things are problematic, you can be referred to the specialist infant feeding clinic, which is weekly on Wednesday afternoon, and it's a lactation consultant midwife who runs that, and there's specialist slots for an hour. So that is a referral process, but generally people get seen pretty soon.
Are details of that in your booklet?
They're not in this one,
Not in
no.
this one, because
It's a newer thing.
Newer since that was published, but they can bleep us. We have a bleep number 1361. If they just ring switchboard and ask for the feeding team, they can bleep us.
I think I put this. Did I put this information on the
your
website? So it is on,
and
and I'll post it again today. It has got a link to a PDF version of this, and I think I put the details, the contact details to get in touch.
Occasionally, there's just like, so Monday there was just me on, and then maybe I'm going teaching for 3 of those hours. Sometimes I'm teaching all day, so on rare occasions there's no one in, but we try to cover it as best we can. I think when we've got our 2 new starters, Claire and Laura, starting with us, that will help as well. But yeah, we always need more resource.
Of course.
Sadly, money is so tight.
Okay, so the next one says, I'm going to try and combi feed the baby when it's born, but she's really anxious about knuckling the breastfeeding to start with, as she has so many issues with her son, and she wants to know whether she needs to establish exclusive breastfeeding first before she tries to combi feed, and does it affect milk supply?
So I would say if you wanted to combi feed, it is best to try to optimise your milk supply first. So we recommend, if you're going to combination feed, if you can, to exclusively breastfeed for the first few weeks and then introduce formula once your milk supply is more established. It's possible to mix feed from the start, it just has a much higher rate of problems. So we wouldn't be doing our jobs if we didn't warn you about the potential problems. So I would say if you can establish your milk supply, it's much easier to down-regulate it than it is to up-regulate it. It's very, very difficult to up-regulate milk supply. So your prolactin receptors, your little receptors inside your breast, which are like little light switches, turn on every feed. Every time you put the baby to the breast or hand express, it doesn't need to be direct breastfeeding. It could be expressing by hand or by pump. You're going to turn on those light switches, and once those receptors are on, they're on for the whole lactation. However, if you don't switch all your prolactin receptors on, you'll only have enough milk for how many you have switched on. So say you breastfed a third of the time, that's how much milk you'll have. And frequently what we find with introducing bottles, particularly of formula milk or express milk, is that babies develop a bottle preference very quickly in some cases. Some babies will happily swap between the breast and the bottle and always go back to the breast and happily do that. They are absolutely in the minority. So the majority of babies will quite quickly develop a flow preference. So it's not because they're lazy. Babies are not lazy, and if anyone tells you they are, that's rubbish. I hate it when I hear you know, start saying babies are lazy, which they don't, but mothers often say he's really lazy and he prefers the bottle. It's because they develop a flow preference. They're evolutionary programmed to feed in the most effective and easy way possible. So if they're getting a bottle, which they have to put far less effort into drinking, they're going to find that easier. And when they then are put to a breast, where they have to stimulate the milk ejection reflex, the letdown reflex for a couple of minutes with sucking, they're going to come off because they're going to say, well, there's no milk there, because they want an instant hit. So that's one of the things we often employ in our role when we're trying to support women generally with feeding challenges, is to stimulate the milk ejection reflex before we put the baby to the breast. Whether that's preterm babies, jaundiced babies, weight loss babies, so babies that need a bit of extra help because they're going to run out of steam easily, or whether that's babies who are very used to a bottle when they're transitioning back to breastfeeding, say if they've had a tongue tie and they haven't been able to latch the baby until after the procedure. So we get mums to, you know, really think about priming their supply first if they want a combination.
Do you recommend at least 3 weeks, 4 weeks?
If you can. I try not to, you know, it's just whatever you feel you can do. But yeah, 3-4 weeks would be brilliant if you can. But any amount of breastfeeding, any amount of breast milk even is brilliant. You know, we need to value, even 10 mils a day is worth it. It doesn't feel like it. And a lot of women, when we see them and they've given a bottle overnight and they've hit the wall at 2 a.m, which is really common, and they say, I've ruined it now, I'm just going to go to bed, there's no point now because it's had a bottle. And we say, yes, there's every point if you want to. How do you feel about it? You know, and they kind of have, some women feel that it's all or nothing. It's very black and white thinking. And we need to move away from that because any breastfeeding, any breast milk is precious and is full of all the good stuff. So, you know, just even if, as I say, it's only 10 or 20 mils a day, it's still worth giving if mums are happy to do that.
I think that's the key point. I know a lot of mums say that they felt pressure to breastfeed because of various things, and the midwife was forcing them into it, and the health visitor was really forcing. But it doesn't sound like everyone just wants the best for both mum and baby, don't they?
Exactly.
It is just a case of making sure mums are informed about all the benefits of breastfeeding. And I think lots of mums are, but it's easy when you have had the baby and you're in that little pit to just get in a spiral of kind of, I don't know, just sadness about it all, and do just think, well, it's not worth it. And some mums for their own sake. I mean, I breastfed my first for 4 months exclusively after I built up the supply, so loads of issues, and then I expressed for another 2 months. So she had breast milk for 6, but I still feel like, oh, it's not very much when you think about it. But I hit the absolute, I cannot do it anymore. I was trying to build up my supply with so I was feeding on the breast, then giving her a bottle, then expressing, like every feed. So when that's 2 or 3 feeds a night, I was just completely done. I think a lot of mums do feel quite guilty about everything, don't they? We always have the guilt.
Yeah,
I think however long you feed your baby for, you feel I could have done that for longer. I still feel guilty, and because I stopped my son when he was 3, and I still feel guilty because I didn't have any support. I didn't know anyone else who was feeding an older baby, and I thought I was a freak. And I didn't want to talk about it with anyone. I was ashamed. I felt embarrassed. You feel pressure from
you know, and I was a lactation consultant and midwife for years. So you know, I'm sure I don't want to be sexist, but I'm sure if men were feeding, they wouldn't feel guilty. I just think it's a very female thing to feel really guilty. And once it's not feeding, it's everything else. Let me tell you, my son's just gone to high school, so I'm still going through all these milestones where you think, I don't think I did that well enough. I didn't do that well enough. But yeah, breastfeeding is incredibly hard for some women. Like getting pregnant is so hard for some women, and carrying a baby and giving birth. For some women, it's incredibly difficult and they get really unlucky, essentially. And it's the same as feeding. And some people breeze it. And you know, I always wanted a beautiful water birth, and I didn't. I had 2 horrible births, and I did everything I could and all the optimal fetal positioning in the world. And it hurts, and the same way that you have birth trauma, and birth trauma is such a real thing and affects so many women, there's definitely feeding trauma, breastfeeding trauma, and breastfeeding grief is a real thing. And what I personally would love to see is a much better service is to debrief women from traumatic feeding experiences.
Someone wants to know why we don't teach mums the pros and cons of both breast and bottle feeding. I'm not sure. Do we just focus on the benefits of breastfeeding because everyone, you know, wants to push that?
I think it's a really interesting question. So, like in the question she was saying, we teach pros and cons of pain relief in our pathway to parenting antenatal classes. So, I think with breastfeeding, sometimes It's so emotive. It's such an emotive topic in the UK, particularly where we have so many women who've tried so hard and not succeeded in their own goals, whatever their goals were. And as we were just saying, that causes a lot of trauma and grief and guilt. And so we've got a whole generation or three of women for whom breastfeeding wasn't what they hoped. And that really feeds into everything around us. So we're desperate to believe that it doesn't really matter how you feed your baby, because God, it would make our job so much easier if there were no health outcome differences. If it was just Pepsi or Coke, what do you want to do? Breast or bottle? But unfortunately there are, whether we like to hear it or not, and I appreciate it's really painful for some women to hear, there are significant health differences in outcomes, and we only need to look at the research to know that. And our job is to sensitively and gently inform women about that, and our job as midwives is to do that, and that's why we use the Essential Guide to start conversations. But we don't want to have a checklist of, did you know that breastfeeding reduces the risk of, and be very didactic, because that doesn't help anyone. What we want to do is explore women's feelings. So how do you feel about, what's your thoughts about, asking open questions and accepting if women say, I want to bottle feed formula, our answers to that should be, okay, how can I support you with that? Not, well, have you thought about it? So exactly. Yeah. So, and again, that's baby-friendly ethos, and we've been training these baby-friendly standards and baby-friendly communication skills for years. So it should be embedded. And if anyone hasn't had that experience, please feedback to us. Please let us.
I think we've spoken before, haven't we, about how everyone's situation is different. Absolutely. And one person's pressure from feeling like they're being pressured by someone would be support to another mum. It all depends on everyone, what's happened, like how the labour went, how the feeding's gone so far, and it's a very personal experience, isn't it? So some might feel like it's someone's pressuring them, and someone
asking them how feeding is going. How's feeding going? Could be interpreted as, oh God, So we need to be very sensitive, and as midwives and MCAs, we're trained really well. And, it's the most vulnerable time in a woman's life. Most of us that have had babies or can empathise if we haven't had babies ourselves remember it as, I have never felt so vulnerable. So we're aware of that, and we know that our emotions are heightened, and we're used to dealing with people as sensitively as we can, but we don't always get it right. But what we did do was we audit mums, breastfeeding and bottle feeding mums, and mums with a baby in the neonatal unit, and we audit 30 in each category, so 90 mums every 6 months. We used to audit every 3 months until we were accredited. And I added a sneaky question on, and we audited 120 mums and asked them, did you feel pressure to breastfeed? Because I was really interested in this, being the infant feeding lead, so it's important to me that people don't come to the service that I'm leading in terms of infant feeding and feel that way. And only 2 out of 120 said they felt pressure from staff. Most of them said they felt pressure, and when we asked where did that pressure come from, they said myself, my partner, society, my parents or my in-laws, and so they acknowledged that they did feel pressure, but actually that pressure came often from within or from society, so not from staff. And the 2 women out of 120 that described what had happened, I was able to take that up with staff. So it's really important to us as a team that we know about any incidences where staff have made women feel that way, because that shouldn't happen.
Okay, right. Next one is about preventing mastitis. Is there a way, is there a warning sign, something you can do? Is it just a case of bad luck, or is it an actual reason why this happens?
Well, firstly, going back to the real basics of making sure that positioning and attachment is really good for with baby, because then you're draining the breast effectively. Also feeding in response to baby's feeding cues, rather than kind of watching the clock and saying, oh well, I fed them an hour ago, I must leave them for another 2 hours. If you don't respond to your baby like that, you're more likely to come up against different problems, one of which being your milk supply being a problem. So feeding kind of responsively, following baby's cues, making sure that attachment is really, really good at the breast, and positioning. And I've got blank.
I think making sure any damage, because mastitis is usually just stasis of milk. It's just milk that's stuck in the breast and hasn't moved, like say with engorgement or ineffective positioning. So it's poor drainage usually. But sometimes it's actually bacterial infection that's got in through a crack in the nipple usually. In very rare cases, it's we think migrated from things like a chest infection. Sometimes can then move the bacteria in the chest we think some cases can trigger mastitis. So yeah, you've got to sometimes have a route of infection if it's infective mastitis, but whether it's bacterial or not, the route of infection, the symptoms are the same, and the treatment's the same, really, usually in terms of good drainage. But it's awful. I've had mastitis myself, and it's still etched in my memory.
And sometimes you have sort of precursors, so they can kind of give you a bit of a sign that you might be on the route. So it's good to try and stop those. So say for example you're feeling quite blocked in an area or like quite tender, it's good to try and get to clear that blockage as soon as possible. There's different techniques you can do for that. Have a hot shower, hot compress. Some people find cold compress is good. Massage. A really good thing is an electric toothbrush with the actual brush on the end held on the area, and it helps to disperse it. I've done that myself, and it really, really helps.
It's really effective.
Yeah, it really, really helps. Yeah, you can do. You can try and feed the baby so that, say the blockage was up here, you kind of want to feed. This sounds crazy, but feed the baby obviously in a safe and comfortable position, so that the chin is kind of pointing in the area of the thing.
The bit that
it helps to kind of move the blockage. Some people try dangle feeding. Where you put, yeah, you put baby,
over a baby.
you put baby on the bed, get on your all fours, and feed baby in that, like literally like you're a cow, in that way, because it helps again with the
parenting load.
Yeah, something you never thought you'd see yourself
If
do.
you're in so much pain, you'll do it.
Does it just help just feeding from, like, because I always did the cross body one, because that's what I just wanted to perfect one way. I just I didn't want to do all these other methods. I just wanted to do. But would it help doing it in other ways if you did just use one just to help?
Yeah, and you can also express as well. If you feel like it's not working with getting the baby to, you can try.
So it is possible to revert if you feel like you're.
Absolutely. Yeah, and any pain you can take ibuprofen, things like that to help with.
Because often it's really hard to get a milk ejection when you've got a blocked duct. So I can remember having this blocked duct, new, and it just got redder and redder and sore, and I could not clear it for all because it was too high up. And I tried the electric toothbrush, I tried everything, and it did develop to full-blown mastitis, and I yes, go back. So yeah, I can remember phoning my boss, a mentor friend, Jeanette Westman, who started on my journey, who's the infant feeding lead at Bradford, and said, "Oh, Jeanette, in a world of pain." She said, "Have you taken ibuprofen?" First line, obviously, basic stuff that we're taught. No, I forgot. So I'd completely forgotten because I was, feeling rubbish to take ibuprofen. So if you're okay with ibuprofen, it's absolutely first line because it takes down the inflammation to enable the oxytocin to reach the milk cells, the CD cells, and the myoepithelial muscle cells around the milk cells to squeeze it, to eject it. So if you can't get the oxytocin there because it's also engorged, you're never going to get a milk ejection. It will just block. So ibuprofen, absolutely, 3 times a day, 400 milligrams is the first line on paracetamol. This leads to pain and temperature. Loads of fluids. Bed rest is indicated, and if symptoms are not improving in 6 to 8 hours, please go to the doctors and get some antibiotics.
Okay, right. I'm aware that Louisa, you have a meeting soon, so we'll try and wrap it up. I know this is already longer than I thought. But anyone who's sent a message on the comments so far, would you be happy if I forward them on and I'll do the post about them? And I think we'll just end with what you guys think can be done to help give more information and advice about feeding in pregnancy. How can we help new parents?
Provide everybody with an NHS funded lactation consultant.
Oh,
I think
more advice in antenatal classes.
I think that's what everybody says. And going back to the comment about pros and cons of breast and bottle feeding, what everyone says is, why did no one tell me it could be this hard? And I think we need to listen to women, and we really want to look at running a breastfeeding antenatal session, because I know it's covered in Pathway to Parenting, but we're really keen to look at doing that on an evening. We talked about it before. It's just we're so full on.
I think it's easy as a new mum to think, well, I'll just get to that when I come to it.
Exactly.
And then when it's there, you think, actually, where is the support? What am I doing? Like, I didn't.
People just so focused on the birth.
Absolutely. I think we just think about getting past
everyone says
labour.
Yes, don't they? But they don't say, you're expecting it. That's what my friend said. Everyone told me that was going to hurt. No one told me that breastfeeding can hurt and be so hard to establish. So I think it is easy to
know where your support groups are. So we've got a support group list, which you've got on our website as well. We've got on our website for breastfeeding mums, for mums who are mixed feeding or bottle feeding, we cover everybody.
We've also got, so ideally around your 16-week appointment you get one of these from your midwife. If for some reason you don't get one, they are on the website. They're our hospital website as a PDF. But this has got really good links in the back to sources that we would consider reputable, because the trouble is if you go on Google, Dr. Google, and you say, why isn't my baby feeding? And then you've got lots of horror stories and people giving you strange advice. So we would say first port of call places like here, the Breastfeeding Network, Association of Breastfeeding
And the Children's
Mothers.
Service has got a new website coming up, haven't they? They're launching a new website.
Have they?
In
I
October,
didn't know that.
November, I think. Yeah,
Okay,
the one
that's
number.
good to know.
Yeah, the
Oh,
Norfolk
yes,
Children's
yes.
Service. Yes.
So there's different phone numbers, and there's obviously baby friendly. So yeah, this is a really good place to, as a starting point. They've got lots of different PDFs about specific topics. So
we cover lots in that about like reluctant to feed babies, which affects a lot of babies. We have a new hypoglycemia guideline that's much more protective for breastfeeding now. So if your baby's at risk of low blood sugar, say if you're diabetic in pregnancy or pre-existing diabetic, or if you're on certain medications, for example labetalol, then we know that your baby's going to have their blood sugar monitored. And so we encourage those mums to antenatally hand express. We encourage all mums to express antenatally now from 37 weeks onwards. A massive worldwide research trial concluded a year and a half ago, found that it was safe, because before that we didn't have a lot of evidence, so we were a bit on dodgy ground recommending it, but now we can. We've got a parent information leaflet on our website which we give to all women.
So maybe because there's something mums can be doing at this earlier stage that we could spread the breastfeeding information, and people might want to take it on board a little bit more because they can do something.
And as workers sort of postnatally, what we're finding is it's really, really valuable when people come in with their little syringes of breast milk, because if they are having a tricky time in that first 24 hours, baby is really, really sleepy for whatever reason, not feeding, at least we know we're giving baby something from mum, albeit in a syringe. It's preferable to not having anything at all. So that's really, really great.
Okay, right, I'm going to let you guys go. So I just want to say a big thank you to everyone who's watching, and a big thank you to Louisa and Lucy. Sadly, Louisa, you're going on Friday. But
I'm still here with my tongue tied.
Yeah, she'll still be here as a tongue tied. And so many people have messaged to say thank you to you guys for all the support you've given. So a really big thank you on behalf of all mums that you've supported. I think it's a fantastic service.
It is.
Yes.
Absolutely.
So Gail McCartney is going to be the new feeding coordinator doing 3 days, and the other, because it's a job share, the other feeding coordinator is called Jo Naylor. So I'll post a link to the PDF with that essential feeding, with how you can get in touch if you are suffering, and hopefully this has been really useful for people watching. So we'll say goodbye. Bye from the NNN.